So we're going to finish this morning's sessions with a talk from Radhika Yelamanchili, who's from Niagara region, an oncologist, who has been a very strong patient advocate, and she's going to talk to us about advocacy. Thanks.
Thank you. So I think we're running late, so I'm in between you and your lunch, so I'll try to keep it as simple as I can, but I prepared a 30-minute talk, so I'll try to do it as best within the time limit. Okay, so I was asked to give a patient advocacy talk on access to care. I want to add quality care, when possible, closer to home. Sorry, there we go. Thank you. These are my disclosures. I wanted to start my talk with a story of one of my patients. This is a 50-year-old gentleman who started his journey at an academic center, diagnosed with metastatic pancreatic neuroendocrine tumor, grade 2, with liver mets and extensive lymphadenopathy, so he was deemed unresectable, and therefore considered palliative, and was sent closer to home for systemic treatments, non-surgical treatments. When I reviewed the patient, I looked at the path with all the details that I had in my mind that Dr. Asa and Dr. Azat has all been talking all along. I did not like it. It did not correlate with the patient's clinical history as well as the radiological imaging that I had. So I called up the pathologist and asked for more detail. The Ki-67 was originally quoted at about 10%, and then she came back and said, okay, maybe it's 10 to 15%. Did not like the answer. So I asked her to send it to a path review at the nearest net center or the net center, specialty center. And this time I got an answer back saying this was a grade 3 neuroendocrine carcinoma, likely a poorly differentiated tumor, rather than what I heard already. This seemed to correlate with the patient's symptoms as well as the radiological imaging that I had. With that information, I started looking into getting my first-line treatments ready, but then I said, okay, let's look into the clinical trial options. So I actually knew about a possible immunotherapy clinical trial that was in the works, sent him to that center. He was actually eligible for that. The path was once again reviewed, and it correlated with the other net center reading. It was a grade 3 neuroendocrine carcinoma, poorly differentiated. The immunotherapy trial was not quite ready yet, so the patient was sent back to me to start first-line treatments, which I did. Then when he progressed on first-line treatments, we reached out to the trial center again. Still not ready for some technical reasons. He was sent back to me. I started on second-line treatments close to home. I must say, during all this time, he worked most of the 5 days in a week, spent quality time with his kids, and did not have to travel much. So while on second-line treatments, we started looking into options possibly outside the province. Now, given that he was at a lower end of the grade 3 spectrum, at about 30 to 35% was what was noted, we reached out to Quebec to see if he would be eligible for the PRRT trial. Now, with some details there, given the poorly differentiated histology, we wanted a dual scan, both an octreotide as well as a FDG PET correlation, which we facilitated through a net center in Ontario, and send the CDs to Quebec, information to Quebec, and he was actually found to be eligible for that trial. All this time, the patient was in St. Catharines or Niagara. So when he progressed on second-line trials, he had two options open to him, both the immunotherapy trial as well as the PRRT program outside Ontario. He chose to stay in Ontario. He went on to the immunotherapy trial. He was still in a good shape. He was traveling to Sunnybrook at this time, I think every 2 weeks or 3 weeks, depending on the trial regimen. His adverse effects have been actually managed close to home when we needed an admission. I think I see Francis just walked in. He actually took care of him at Sunnybrook, and I took care of him at St. Catharines. So we managed the side effects close to home, and when he needed admission, we took care of it. And immunotherapy is a pretty common treatment in other malignancies, so side effects are pretty well known to most medical oncologists. He closely followed, like Lynn was saying, he had been in touch with our palliative care team. He had been followed for symptom management close to home. Even every 2 weeks, he had ascites, which needed a TAP that has been facilitated close to home. And eventually, when it did come to the time of end of life, that was facilitated closely as well. I must say, both the patient and the family were quite happy with the care that was provided all along, and also to all the options and the net expertise that was offered to them, and while staying close to home, yet having the expertise everywhere that is involved in their care. Is this an ideal or a typical situation? Possibly ideal, but may not always be feasible for certain reasons. I mean, not every center has the expertise, but not every center will be willing to do the coordination. Let's talk more about this. What do the net patients think about their care? What are the healthcare professionals saying? Why is this concept of shared care relevant now more than before? This is a first global survey of patients with neuroendocrine tumors, which was published by Dr. Singh et al. In February 2017. A total of 1,298 neuroendocrine tumor patients from 12 countries participated in this first global self-reported survey between February and May 2014. This collected data on socio-demographic features, clinical characteristics, burden of neuroendocrine tumors on the patient's daily life and work, desired improvements in net management, and the information resources that they used. All relevant. This was carried on by the INCA Foundation in collaboration with Novartis. The results. Net diagnosis was associated with substantial negative impact on their personal and work lives. Delays in diagnosis were reported. Extensive neuroendocrine-related healthcare resource use was noticed. It highlighted the considerable unmet needs in the NET's management. These are some of the graphs I wanted to point your attention. What are the modalities that would help with ongoing management of your NET care? And when patients were asked this, I mean, the most important thing all of us want is a wider range of treatment options. That was the most important thing. But look at the others. Better access to NET expertise, medical centers that specialize in neuroendocrine tumors, more information and opportunities to participate in NET clinical trials, more knowledgeable NET medical providers, and a better coordinated or aligned NET medical teams or providers. When asked about the negative impact that the neuroendocrine tumors had on the daily life of patients, the most common thing, and we all have already heard, energy levels, decreased energy levels. But the other thing too, important detail here I wanted to bring to your attention, my ability to travel and my finances. And that is important and not always talked about. What are the lifestyle changes that the NET patients had to make due to the diagnosis? The most important thing is the dietary changes. We heard a lot about that. We have to miss that glass of wine, as Lynn was saying. But what about the other two? Increased spending on travel for medical appointments and spending a lot of time on travel to and from the medical appointments. Now, distance as a barrier to cancer diagnosis and treatment has been studied previously. In this particular survey, patients traveled a mean of 182 kilometers to get to their medical providers. This was 12 countries. So the distances were as far as 1,900 kilometers was the farthest. So the studies, not just in neuroendocrine tumors, but colorectal cancers, head and neck cancers, we have breast cancer treatments, we have data showing that the travel distance affects decision making. If you're offered a clinical trial 100 kilometers away versus a standard treatment close to home, you probably will go to close to home treatment rather than the clinical trial. It does affect your decision making. Stage of diagnosis, outcomes, and financial toxicity. So we heard what the patients had to say, and this is what the healthcare professionals had to say. This is our work I presented at NANET's meeting last fall. Insights into practice patterns, challenges, and role of shared care model in the management of neuroendocrine patients in the community. Understanding that a multidisciplinary approach is the key to a successful NET patient care, our group aimed to understand the barriers and opportunities in the development of a shared care model between the local medical oncologists and the NET specialty centers. The original idea was developed around a roundtable discussion at the ComNets meeting, so most of us attend, in 2016. A survey including 30 questions was sent to the medical oncologists in Ontario, as well as Queensland, Australia. It was a combined effort So we had colleagues from Australia who collaborated on this project. A total of 74 medical oncologists responded. This was done between 2017 November and 2018 May. 11 out of the 74 medical oncologists were at the NET specialty centers. Approximately 24% of these medical oncologists outside of the NET centers were from Australia, so which means that predominant responses were from the medical oncologists in Ontario outside of the NET specialty center. So that reflects most of the opinions here. 69% of all medical oncologists that responded had less than one NET patient per month, NET new patient that they saw per month. And 43% of them had less than 5 neuroendocrine tumor patients in their total practice. And 46% of these medical oncologists outside of the NET center were at least greater than 50 kilometers, and 20% of them are as far as 100 kilometers away from the NET specialty centers. So this goes to show that the medical oncologists with limited NET experience have been involved in the care of the patients, as well as the distances that the patients had to travel to get to the NET specialty center. We asked about the comfort levels that the medical oncologists had in taking care of these patients. And these are the medical oncologists with greater than 5 neuroendocrine tumor patients in their practice. I'm sorry, the graphs may not be projecting very well, but I'm going to explain. So most of the medical oncologists were comfortable with the care and treatment decisions at the diagnosis, but much less comfortable when it came to progression. They were comfortable with prescribing and managing patients on somatostatin analogs, chemotherapy agents, or targeted agents. These chemotherapy agents and target agents are used in other malignancies as well, so they're well trained to handle those, but much less comfortable when it came to the decisions of either directed treatments or PRRT, or referrals and monitoring while on PRRT. This is showing the interest and barriers. So the medical oncologists who had less than 5 NET patients in their practice, when they were asked about their interest, only half of them were actually interested in incorporating the NET patients in their practice. And I think there are several reasons for this. Barriers were quoted by all the medical oncologists in the survey, and the most important barrier that they quoted was limited or lack of access to nuclear imaging as well as treatments. Lack of site-specific tumor boards, which we'll talk more about, access to the site-specific tumor boards. Lack of clinical experience with the neuroendocrine patients. They didn't have enough experience. And also, they have their own disease site-specific practice, like they're either breast or colorectal oncologists. They don't deal with NET. But also, the patients prefer to be in the NET centers, and the physicians locally felt, okay, there's no need for me to get involved. When looked at the referral patterns, majority of them referred 50 to 75%, not all 100%, 50 to 75% of their patients to the NET centers. And it was predominantly for PRRT or some specialty treatments or clinical trials. Only 10 to 12% of them referred all the 100% of their NET patients that were never involved in their care. And it was for transfer of care, complete care. The predominant coordination was through emails and phone calls rather than through tumor boards or teleconferences that we would prefer, like more standardized methods. I highlighted the qualitative themes from the survey, but I must say they're very similar to the barriers or the concerns expressed in the patient survey. Access challenges, wait times, coordination, lack of coordination, challenges faced by the patients in terms of travel distances, and the need for education of the overall medical community. Like there is limited NET exposure during oncology training, and as well as further in practice. When you're not going to see the patient in your practice, you will never learn about it. So need for ongoing education and more clarity on PRRT. So we concluded that a streamlined process for coordination of care amongst the providers, education, timely access to NET-specific tumor boards, expert services, and PRRT would be essential in the development of a shared care model. Now, we talked about the barriers, which are very similar to what was expressed by the patients as well as the physicians. What are the possible solutions? Timely, better access to NET experts. We have talked, and the medical community has already been working on this, developing the NET-specific, or actually making it even better, NET-specific tumor boards. How does that work? With a built-in path review and a radiology review, the patient gets the benefit of consulting multiple NET experts without even traveling when his case is discussed at the tumor board, or his or her case. Now, you can possibly identify a patient that can be treated locally, keep them there, but the one that needs that procedure or consultation in the specialty center should be then fast-tracked to that NET specialty center and get the appropriate care. And then lack of well-informed medical teams. Maybe we can develop a physician portal for the physicians and the nurses and have information regarding ongoing clinical trials, have access information to the drugs, access information how to get to the nearest expert center, what are the specific services provided by the different centers, ongoing CMEs, and access to nuclear scans. All this information could be there. Now, while we can develop all the physician portals we want, but I think we have to get the message out there, and the physicians actually should get there and look into this. Difficulties with coordinating care. I think something like a NET pathway, maybe something which includes streamlining the MCCs, which we talked about, including the healthcare providers outside of the NET specialty center so that we don't have these silos of expertise and then the rest of the world is left out. Fast tracking or triaging the referrals at the level of the NET specialty centers, maybe having a nurse navigator. Having the local healthcare providers continue to be involved in the care of the patients. Now this, I wanted to quote an example that I got a phone call yesterday, Friday afternoon, 4 o'clock, while I was trying to wrap up and come here this morning, about a patient in panic and acutely unwell, wanting my help. I haven't seen her. This is my NET patient for 2 years. She missed all the appointments with me for the last 2 years. But understandably, she has been very well taken care of at a distant center, but she has now become very ill. Now, I would have been more than happy to help her, but not seeing a patient for 2 years, not eyeballing her, not knowing her, and not having any information in her care, about her care, I felt quite uncomfortable providing a phone advice on a Friday afternoon. So I had to tell her, please take care of your acute medical issues appropriately, depending upon how you're feeling right now, and make an appointment with me next week, and maybe I can coordinate care with that distant center. And if that helps you, and I'll be happy to do that. So I think involving the healthcare providers might be helpful for those sick, unwell patients. Now, the well patients probably who are traveling once or twice a year to the distant center, probably that's reasonable, but not for the other unwell patients. Now, your role. I think we heard so much about you actually knowing the details of your diagnosis, treatment. Knowledge is power. You need to know, and every one of you is very unique, and you need to know those details so that your care can be appropriately guided. Know your healthcare providers. Know your local healthcare providers. Know your local healthcare facility. Because there are many subspecialty services and allied health services that most of the cancer centers outside of a NET center can provide. As Lynn was saying, whether it's a survivorship or wellness programs or palliative care programs, they are all available in general to all cancer patients. Yes, we understand that your needs might be unique, and I think we all have to recognize that, but a wellness program or exercise program is similar to most cancer patients. So utilize the care that is closer to home. Ask more. Know your nearest NET center. How is the care being collaborated? Be your own advocate. Ask your local providers about their NET experience and comfort and their ability to coordinate. They may not have to be the expert. They should be able to coordinate. Services that can be provided locally and services that clearly need you to travel to that NET center. Have a care plan. I think this is very much similar to the CNET's book that you guys have. I found this link on the Unicorn Foundation website. There is a good treatment and wellness care plan. I would like you to look into that. I found that this was very comprehensive. You should check it out. Concluding, there is increasing prevalence of NETs. As Dr. Asa was saying, these are not zebras anymore. And over the last decade, we had multiple randomized controlled trials which have shown or given us opportunities to treat patients with somatostatin analogs, targeted agents, chemotherapy, symptom management modalities that can be delivered outside of a NET center. Now, that doesn't mean everything can be done locally. You need to have that NET expertise opinion, and whatever can be provided locally should be provided, and then you have to sort out that expert help as needed at every transition point in your journey. Improved communication abilities. In 2019, in the era of technology, telehealth, video conferencing, I don't think patient needs to travel as much. We can coordinate better. Increasing net awareness, involvement of local medical teams might just have that ripple effect of increasing awareness, promoting early diagnosis, and more importantly, decreasing misdiagnosis. If I didn't move with the NET community, I probably would not have double-checked the pathology. So that awareness need to be improved. I probably would have treated him with something which was not appropriate for him. So I think getting your local healthcare providers might just have that bigger picture, like might do bigger good, if not for you, for the whole community, but I hope it does to you as well. So management of neuroendocrine tumor patients in 2019, it's a team sport. Find your quarterback. I mean, he doesn't have to be the expert in everything, but he should be able to bring all the experts on board. Thank you.
Great. Thank you. What a great place to end. Thank you so much, Radhika. I think that's been a great conclusion to a morning where you've gotten a lot of great knowledge and information and ideas for how you can manage your care and your friends' cares. We're going to take a break for lunch. We will start again at 1 o'clock. I want to remind everybody that this afternoon we're going to have some discussions about treatment, and then we're going to break up into round tables where you'll be able to focus on different aspects of what we've already talked about today. So enjoy your lunch, and we'll start again at 1 o'clock.